Thank you, Dr. Rosalie. Now we are going to PIC again to see the results. Dr. Bashir Ani will take care of this procedure.
Salman, we are back to you. So, if you could quickly show us what you have done so that we have to move on to Turkey for the next case.
Test.
Can you hear us?
Is this one on?
Salman, can you hear us? I think they're not able to hear us.
यहाँ पे थोड़ा puff कीजिएगा.
Yes.
Salman, can you hear us?
Yes, we can.
Okay, so I think we are back to you for a few minutes only. So if you could tell us what you have done, because we have live ready in Turkey.
Achha, and we actually need your opinion. A very important question. Let's go back to the fluorogeist जहाँ पे हमने खत्म किया था. Let's just. So you saw us when we were trying to get the guide extender in. I think there's a kink in the guide. That's why we could get the guide in next. Next. So we tried a 2O balloon. We tried to do bat. And again, you can see this is, we tried to swallow the guide. So we tried to do bat, but again, there's a kink in the guide there. We just can't get it. So what we did was we deep seated the guide by anchoring. So while anchor, you can see the guide is much deeper. Next. Next. And see the guide is really deep now. Next. And this gave us a support to go with the 1.5. We took a new sapphire balloon, a 1.0. Next.
Balloon down, please.
Yes. Next. So now we're in the wire, and you can see we did a simultaneous picture, but the mechanism of failure is now clear that there's actually a lesion distal to the stent. So we had only gone with about distal to the stent. So we took a new 1.5 balloon and we went further than that. Next. Now we're at the bifurcation and we worked our way back. Next. Please stand, show us the picture. And then this is what we found. So now you can see that we're in true vessel. And you can see that focal calcified nodule at the distal stent edge. That was probably the problem. Next. But we had to make room for the IVUS, so we went with the 2O balloon. Next, and let's just go to the IVUS now. Show us the picture, PCI. So this is our picture. This is what we see now.
Yeah, it's a good size vessel actually.
It is a very good size vessel. The IVUS is very interesting. Let's go to the IVUS, please.
IVUS first round. First round.
So can you show us the IVUS? We are not seeing the IVUS.
Yes. Yes.
IVUS, the Khatanji, can you put up the IVUS?
Move camera to IVUS.
Focus on the.
Focus on IVUS.
Focus on IVUS. Please transmit the IVUS.
Transmit IVUS, please. एक pause कर दे IVUS. यहाँ pause कर दे यहाँ पे. Let us know when you see the IVUS. It's very important to see this IVUS.
What I can see.
Yes.
You got transmit करें IVUS को यार यहाँ से.
Transmit. हो रहा?
First run, yeah. हम बस pause कर दें एक second. Yeah. There we go. So that's IVUS. Play please. IVUS play कर दें. So you can see this vessel is about 2.25 distally. Now it might be a little spasm because there's a lot of circumferential plaque. If you see the adventitia is much farther out. And look at the stent, it's very undersized. So this is where we angioplastied, and this reportedly was a 2.5 stent, and it is 2.5, but you can see how it's just hanging within that vessel. All the way to the guide. Achha, so we decided to then go ahead and do a pre-dilation of the stent with a 3.5 non-compliant balloon. Anju, dikhaiega?
Anju.
Next.
So this is a 3.5 non-compliant, and the stent is visibly much bigger. But look at that. Wow. So the vessel is starting to plump up distally. There's blush, but there's a high-grade stenosis where that RV branch takes off. So we decided to take another view to make sure there wasn't a stent fracture there. Next. So this is a high zoomed-up view. And it's hard to tell whether this is thrombus or calcified nodule or calcified ISR. So we decided to do another IVUS run. The second IVUS run, dikhaiega?
Second.
So this is the second IVUS run, and you can see that little nodule right there.
So,
And it's possible that this is hardened new intima, calcified, or maybe it's possible that we just missed it with our balloon the first time round. So we went back with a 3-5 non-compliant. Next.
so this was a new atherosclerosis instead of like true ISR with intimal hyperplasia or that kind of thing, because obviously
Exactly.
it's more than 7 years.
So, new atherosclerosis takes about 5 to 8 years, and this
Yeah.
stent is 7 years old, so it's quite possible that this is a double whammy. So you have an undersized stent, distal disease, and new atherosclerosis, so triple whammy for this ISR. Acha, next. So now this is where we are.
So,
You can see that
planning to stent like all the way, you have to do another kind of a metal jacket.
no, we don't want to do that. So one of the things, I think the vessel, typically these vessels will plump up. So we're going to do a DCB. We
Yeah,
sized it, we think a 275 DCB for the
So-
distal portion.
So we
This is
just
the
had a
DCB going
talk
on.
from Dr. Rosalie on DCB, so maybe we can have a comment from Dr. Rosalie. Would you do a DCB in this patient, or Dr. Rosalie, are you there?
Yes.
So it's okay.
Okay. I think if let's say it's just per se or stand under deployment, and if the vessel size is inadequate, I would just take a large balloon, non-compliant, dilate and then I use the DCB. But if let's say the stent, the vessel is too big, and you find that the stent is not going to be able to give a good radial force, then this is something that you may consider to put in the stent.
So the stent is, I think it's a Promus, it's about 7 years old, but we did get good dilatation with the non-compliant balloon, and even on IVUS it looks much bigger. Let's go to iliocranial so we can see a view. So this is going to be our first
Salman,
picture after
if
the
I may make a
DCB.
comment.
So let's see this picture, and then we'd like the panel to weigh in. I know time is short, but we want the panel to weigh in what to do with the instant segment, because distally I think the DCB looks quite good here.
Dr. Rao, what would you do in this case now? You have seen the case, it was a stent, inside the stent occlusion, CTO distally, took a while to open it up, and now this is the result. So would you stent the whole thing, DCB, or what would be your plan?
Another comment, Salman. Do you take a contralateral injection to see if there any vessel which is still blocked? And because the PLB was considerable in the last contralateral injection, it's still not fully visible antegradely here. So maybe if you can open up and then, like we just discussed, do the DCB in the distal vessel and the stent also. But I think that mid portion has to be stented where there's a lot of triple whammy going on.
Yeah, because if it is new atherosclerosis, obviously.
Okay, here's a contralateral injection.
Dr. Rao, can you comment? Can you get a comment from Dr. Rao, please?
Really nothing left. I think this was a naturally smallish RCA, which now we've got antegrade flow. I think to secure, there's still that flap, you can see the haziness. So distally, we've done the DCB. We've covered the distal 1/3 of the stent. So maybe we'll put a DCB up top and a DES up top to secure and keep the flap from falling into the lumen, to obscuring the lumen. What do you think?
Well, so, the flap needs to be stented. Salman, you need to secure that, but the rest of the stuff can be DCB'd, including the distal vessel.
Swell, can I get comment from Dr. Rao? He's waiting for, if you don't mind, please. Dr. Rao?
Yes, immediate after the non-compliant balloon angioplasty, did you check the IVUS again for we have to define whether there is a immediately acutely formed stent thrombosis or the protruded thrombi or the organized plaque, protruded plaque.
Let's do the IVUS now.
They can be resoluted by the more prolonged balloon inflation, non-compliant balloon inflation, or the requiring medical therapy with GP2B3 receptor blocker, something like that. And then we have to decide whether to go to finalize with the TCB or another stenting. If they can be resoluted with the medical therapy, maybe we can finalize with the TCB. If the flow limiting, the fixed region are not there, then we can finalize with the TCB. But that maybe some plaque protrusion and will not be resoluted with the mechanical elaboration. Maybe We can do, but this was a stented city or total occlusion. Then maybe prolonged inflation we can see more effectively with the prolonged balloon inflation, the balloon response to this something new region.
Okay, thank you. So, Salman, if you could just tell us what is your plan, and then we have to move on to the next case. So, if you could tell what is your plan now?
My plan is to do the IVUS, and I was hoping you tell me the next plan, whether to do a DCB or stent. I think it's getting caught up in that.
Maybe Tahir. Naeem is there.
So I'm impressed by the lack of instant research.
You muted yourself, Naeem. Can you unmute yourself?
Sorry. Okay. Yeah, Salman, I'm impressed by the lack of instant restenosis after your balloon, and that what I'm seeing in the angiogram, like other folks said, I'm worried more about a thrombus as opposed to a calcified nodule. So I would definitely do another IVUS and look at that. And if it is a calcified nodule, obviously you're going to put another stent in.
Well, Naeem and Salman, if it's a calcified nodule, I don't know if you have IVL there. A short wave would be good, otherwise the stent may not expand.
Yes. You know, so first of all, this guide is horrible. I can just tell you right now, it's got kinks, it's softened, now our IVUS won't go. But let's go back down, please. I think IVUS, I'm going to take it out. Let's
okay. Salman, we can let you carry on, and maybe we can...
So we've already done 2 inflations with the 3.5 non-compliant at 24 atmospheres, 22 and 24 atmospheres. So it's a persistent haziness in there. And I think at least that we have to restore laminar flow. So whether it's neointima or I don't think it's prolapse tissue. I think the organized thrombus idea is a very good idea. I think we have to restore laminar flow just in that one area. What do you think?
Okay, Salman, I think...
Yeah, I think you'll have to put a stent in. If your balloon, non-compliant balloon expanded, you're going to be able to put a stent in there.
Yeah, but if it is not expanded, if you are going to put another stent in there, the likelihood of restenosis is going to be significantly high if it is not fully expanded.
So we've already expanded to 3.5, so we'll take a 3.5 stent and we'll just land it at that RV branch, because up to the RV branch, I don't know if you saw the little test that I did, the DCB came up to the RV branch, and up to the RV branch, the IVUS looks good. That nodule is all above the RV branch. So maybe just put a short, like a 3.5 20 stent up top and then see how it goes.
Okay, Salman, I think why don't you carry on, and maybe we can try to come back to you later on, see the final result. We'll have to go to Turkey to do the live case from there, and then we'll come back to you again. Thank you.
Perfect. Thank you so much.
Yes. That's great. Yes.
So let's do this, and then the LED भी फिर आज करके वो ना करना है ठीक है
Stage LED है
no stage perfect
कल कर
and you can do the take a perfect तो उन्हें फिर बता दें कि हम 10 minutes तक आते हैं नबील किधर है
440 पे चेक की
हाँ जी 575
नबील है
Okay, hello. Can you hear us, Dr. Kadia?
Recheck.
या नबील अपनी अच्छी वाली कॉफी को मुझे कॉल कब चाहिए
Dr. Tahir Sajid from Pakistan.
हाँ ये भी खत्म हो चला चले can I have that stent please?
Dr. Kadia, can you hear us?
523.
Dr. Kadia, can you hear us? I am Dr. Tahir Sajid from
Can
Pakistan,
hear you.
Lahore.
Hi,
Hi, how are you?
I'm fine, and you?
Yeah. Can you explain your
With
case?
my with my warm regards, then Istanbul. Firstly, I would like to express my thanks to organization committee invite to us this great meeting. Firstly, I would like to introduce my team during this case. As you know, I'm Dr. Kadriye Kılıç Kesmez. Dr. Gökhan Çetinkal will be second operator. Nurse Süleyman and Fırat and technician Latif we will be together during live case. Dr. Erkan Kalender is present case for you. After that, we want to discuss with you and panel.
Good afternoon, everyone. I am Erkan Kalender, an assistant doctor in Cemil Tasci City Hospital. Today, I will present a case of complex coronary intervention. Let's start. A 44-year-old male patient. He presents with typical chest pain, which is started 1 hour ago. And he was diagnosed with acute myocardial infarction at our emergency department. Patient history has ischemic heart disease at 2019 on right coronary artery, 2019 also intermediate artery and circumflex artery at 2015. There was a stent implantation. The surface ECG shows that ST segment elevation on D2, D3, and AVF, and also there was a reciproc on D1 AVL and V4 to V6. Here is the surface ECGs. The first ECG is taken at our emergency department. As I said before, there is an ST segment elevation on D2, D3, and AVF, also reciprocs on D1 AVL and V4 to V6. The following ECG at our coronary care unit, as you can see here, there was an ST segment normalization, and we have acquired pain relieving from patient. Coronary angiography, during the procedure, it was observed that the distal part of right coronary artery where a stent had been implanted 2 years ago was completely occluded. Also, LAD and diagonal lesions were identified. We have performed on the right coronary artery percutaneous balloon angioplasty, and the time-free flow has been acquired. In addition, the patient received intracoronary and intravenous administration of tyrofibin. Here is the coronary angiography views. You can see the LAD and jakes on these views, the left systems. Here we can see the cortical stenosis on mid and distal part of LAD. As you see here, there is a well-developed diagonal artery which is originated from the narrowed part of the LAD. But the current lesions was on right coronary artery. Here is the first images in here. There's a technical problem, sorry. It was totally occluded, the distal part of right coronary artery, and it wasn't stent thrombosis. We have performed an percutaneous balloon angioplasty on the distal part of right coronary artery, and TIMI3 flow has been acquired. And these are the final images. As you see here, there is an TIMI3 flow, and we have acquired the pain relieving. Now we will continue live case, and I give the floor Professor Kesmez. Thank you.
Hi again. I would like to show you our live image now. We have inserted 7 French radial sheet for right arm. Could you show us? Can you see our real image now?
Yeah, you can see.
Okay. As you see, there is not significant lesion circumflex, and there is a stent intermediate artery. Could you show another image? This is a left cranial image. You can see here there is very huge diagonal artery, and also there is very significant lesion, proximal LAD, mid to distal LAD, and also diagonal proximal part. Yes. One more, please. You can see here there is a very tough narrowing in the distal parts to LAD. Yes. We pass to floppy wire, LAD, and diagonal artery, and we did IVUS. Could you show us the IVUS image, please? We start to distal part to LAD. There is a significant plaque. This is a distal part.
So this is a case of acute ST elevation MI.
Yes.
And you have done the open the distal RCA and give Tirofiban. And the same sitting, you are also tackling the non-culprit artery.
Yes. We opened the culprit artery. Culprit artery was a RCA. We opened the RCA because it was a stent thrombosis. We did a balloon. Okay. In this situation, I would like to discuss the case. Are there any comments or any advice about the procedure?
So Elaziz Saab, can you have any comment?
I think the acute vessel has been dealt with, and these are like, mid is critical, there's some moderate lesion proximally. So it will be a great case to see the significant lesion and how it is done. So IOS is a good way of doing it. If you've got multiple lesions, you've got to assess and make sure that you get the right vessel. So probably all these procedures, these imagings will help us decide which vessel to target. It should be a good discussion.
Jan Noori Saab?
Yeah, Naeem Tariq Ali. And I think that proximal LAD at the septal origin is also pretty tight, so may have to do that too. I think we'll see that on the IVUS.
Actually, the RCA lesion is not a de novo lesion. It is a post-stent, and it thrombosed, and it was reopened. So it is not the same as it is a new, fresh lesion and opened and stented.
But it was manifested in the ECG.
Oh, of course, yes, I agree that. But the scenario is different, background is different.
Okay.
So I think there's a point in going for the LAD as a next.
Just a question for discussion, especially Naeem, Tariq Ali. The LAD mid looks quite critical, so if that's done and then an FFR is done for the proximal LAD, would that be a better choice, or doing an IVUS all round would be a better choice?
I think so. The part that is being said is it's a stent thrombosis, but it is an acute MI, right? So in STEMI, then you decide if you're going to do a complete revascularization or not. So STEMI has been taken care of. So at this point, IFR or IVUS, either one would be okay. I think there's no additional advantage of doing an IFR and spending an extra amount of money on FFR or IFR at their point. I would, if the IVUS shows it, fix the distal, which will be tight, and I suspect, General Saab, you've been doing this for a very, very long time, as I have been, so that proximal LAD is going to be tight too. So you just go ahead and fix it at that point. That would be the, a STEMI way of doing it. Just get it done and be over with. But of course, you can certainly, for academic reasons, can do IFR or DFR, and then step backwards and go distally and see how what your step down is in the distal LED or the mid LED lesion, and then also look at what the step up is for the proximal. And you definitely, you could choose to fix the distal one first and then do the DFR for the proximal, or vice versa even. And so it's different questions, but I think just looking at it, I would just do the IVUS, fix the mid and the proximal, and be done with it.
Dr.
Just a
Tariq
question
Shahab,
for
what's your take
discussion.
on this? Dr. Tariq Shahab.
Yeah, I agree with Naeem that once the acute vessel has been taken care of, the LED lesions look like it is very significant, and the proximal would be significant also. So both may have to be dealt with. The FFR can be done, but as we know, in the setting of acute MI, your FFR may not be very reliable.
What exactly is the advantage of an IVUS right now? I mean, the mid looks critical. That's one. And the other is, should one have a lower threshold for stenting the proximal LED, considering it is a huge area it supplies versus a similarly moderate lesion? Or I'm not saying one goes around stenting moderate vessels, but should one have a lower threshold for doing a PCI of the proximal LED than other vessels?
I think one should take a little more cautious approach in this patient. We've tackled the right, which was the culprit vessel. We should stage the LED for the next stage. The reason being that in acute MI, you have an element of vasospasm, so you cannot exactly size the vessels. The distal LED or the mid LED certainly needs to be stented at a later stage. But as far as the proximal LED is concerned, that should be investigated further with FFR or IVUS and then stated later on. And if the right coronary artery stent is still underexpanded, we can do this now in the second sitting, and that is the advantage of staging these procedures.
Sure.
Yeah, I think that is true. You can stage the procedure, but I think the operators here decided to go with the LED, which is also a reasonable approach, as we know from the studies. You can do it in the same settings, or you can even stage them. I usually tend to stage them to limit contrast, especially in the setting of acute, and bring them back later unless there was a critical lesion. So both the options are reasonable, I think.
Dr. Asad Pathan.
So I think if the case is being made that this was the right stent thrombosis, I think if you're not IVUSing or imaging it somehow and leaving it with just balloon, I think you're doing a disservice. I think you can make most evidence-based decision for imaging the right stent and optimizing it. The way it was looking, I think there's a very high likelihood that it's a extremely underexpanded stent. So that, I think, statement one. I don't think the message should be going around for STEMI non-culprit vessels that we make decisions to treat artery just based on IVUS criteria. I think IVUS helps us in how to treat the vessel, whether you should treat or not treat. I think there's most evidence for using physiology or some kind of flow parameter. And I think the third statement that was made, that FFR in STEMI is not reliable, that's actually not correct. If you're doing FFR of the non-culprit vessel, it's been shown that it's reproducible. If you come back and repeat the FFR, you get similar readings. I think you can do FFR in non-culprit vessels during a STEMI situation. So I think the distal LED looks severe, probably 70% or more, so there's a very high likelihood that you'll have a abnormal FFR over there. So I think I agree with Suhail that you just go ahead and treat the distal LED. It's supplying a large area. Proximal, I think angiographically is moderate, and I think you can make a good case for using physiology over there.
Thank you.
Can we have ask them what their plan is?
Can I respond to that real quick? Those are excellent points and absolutely true. The only caveat I would add there, Asad, is the discussion about stable angina and a STEMI are two different things. So in STEMI, our discussion about should we do physiologic, should we not do, is still, still a matter of debate. And so as soon as you get into a STEMI, then you basically are looking at which one is the culprit on the other side, and do you need to fix it or not fix it? And IVUS or DFR or FFR, either one of those are okay, or even without them are still okay. They're okay as far as guidelines are concerned. You don't have to do the DFR, FFR as you have to do for a stable angina, for example. But your point is very well taken. The other part is about staging the procedure. So I would say that, with my gray hair, I always try to stage cases. When you're doing a STEMI, you're involved in that, stop, come back, take your time. But a lot of people do it at the same time for the patient's comfort also. And if you've been able to do it with a small amount of contrast on the other side, you can. Both those approaches are not wrong. And doing physiology is always good, but it's not quite as strongly advocated or absolutely why are you doing it as it is in stable angina. So that would be my point. So
I agree with Naeem that in the patients with acute MI, obviously it is not the same as treating patients with stable angina. I usually tend to stage them. I don't do it at the same sitting unless it is necessary or a patient is still having ischemic changes on the EKG or is having angina. But most of the time I usually stage them. And if you have a tight stenosis and you plan to treat it, then you go ahead and treat it. You don't have to do a functional study.
Okay, thank you. Okay,
Can we ask the team to share their plan with us? And can we ask Omar to please,
share
Omar,
your plan?
can you join us up in the panel, please?
Yes, I would like to share with my plan, and also I would like to discuss with you. Show me later, Mitch, one more. Come back. I would like to ask again, what do you think about drug coating balloon for distal part to LAD? Can we use a drug coated balloon for this lesion?
Yes, so do I.
This one?
The question is, can we use a drug-eluting balloon for this lesion in the distal part?
Yes, distal LAD lesion. Because when I implant to stent, it looks like all of the segment stented to LAD proximal to distal. I have to explain. I try to dilate it with balloon. I have planned, can I make a drug-coated balloon this segment? This is a NC balloon. As you see here, when I inflate the balloon, it slides to backward and downward. Yes. I put the second wire. After the NC balloon dilatation, I think I don't have any chance to drug coating balloon. What do you think?
I don't know if there's a data to use drug-coated balloon in such de novo lesions, especially that you have already stented the right and the patient is going to be on a dual antiplatelet therapy. If there was a reason that patient is you want to avoid long-term antiplatelet therapy, and there was no stent in the other artery, then of course, but there will be no difference if you put a stent there. That would be better than a drug-coated balloon in this situation.
But I think I don't have any chance for drug coating balloon, and I have stented this segment. I implanted 3.5 32 millimeter microport Firehawk stent this segment, and I have post-dilated with 3.5 balloon. And in this situation, we have to discuss the strategy for a proximal LAD, or maybe we can do FFR, but there is a retrograde flow, and this patient had the acute myocardial infarction just 3 days ago. I think we can stent it, this lesion.
Kadria, when you have the IVUS run, what about the status of the proximal part, that is the tortuous part of the LAD?
Yeah,
what
we
it
can
looks
show
like.
you proximal part. Show us the proximal part.
Distally also the stent looks like it may have landed in a significant plaque burden. The distal portion of the stent also, so I just can help with that in terms of...
Right. This is a proximal part.
Probably, but I will still help with that.
Stop. One forwards. Step by step. Can you see here?
Yeah, we can see that.
Yeah, there is a significant lesion, proximal LAD as well. And also diagonal as much as larger the LAD, and there is a significant lesion. I have planned to double kissing cloth for this lesion. Do you agree with me or not?
Yeah, I think that's a good strategy. You can obviously use multiple different strategies, but cool out is as good as anything else that we would do it there.
No. 18, yes. I pre-dilated with a trio balloon. Yes. Test. Test. 18. 20. Right caudal. Down. Down. Test. Image. $22. Down.
Hello, Kadri. This is Ömer. I just came to the hall, and what I see here, I think this patient has instant restenosis, and you did.
I think it's stent thrombosis. There is not a stenosis.
Okay, in the LAD, right? In the RCA.
No, RCA. I'm speaking about RCA.
Okay.
He admitted to hospital inferior myocardial infarction with RCA stent thrombosis.
Okay, so we have to check the RCA stent as well, right?
Yeah.
Today.
We did it 2 days ago. Yes, 3 days ago. It's open.
What was the IVUS like on the right coronary artery stent? Was that underdeployed, or was that a stoppage of Plavix or Effient? What was the mechanism of the stent thrombosis on the right side?
Unfortunately, we didn't IVUS to RCA. Maybe we can do after this procedure.
I think of all the things that you're doing, that's probably the most important thing, because he showed he had a MI, and if that is under deployed, that's what you need to do, is to make sure we post dilate it, and that doesn't happen unless he stopped taking his Plavix, or I'm not sure if it's something like that.
He smokes still. I'm not sure this is the real, but he is still.
That would explain it.
Yeah. Okay.
Okay, so for the LAD, we have instant restenosis. What did you do for LAD? Just stenting?
For proximal part?
No, for the mid part. Mid part of LAD.
Yes, I have stent to LAD. I have plans to drug-eluting balloon after predilatation, but there was a very significant dissection after a NC balloon dilatation. I implant to stent distal part to LAD, mid to distal part.
Okay, right.
Okay. But I'm not sure about this. It is really open very well. image. What do you think about this? Doing rota like this?
Rotablation, you mean?
Yeah.
I didn't see, is there any, I think balloon looks okay. Is it trio balloon?
No, it's 2O balloon.
Two.
2O.
No, this is a trio balloon.
Trio balloon.
Yeah.
Maybe you can try with the 3.5. If it
Yeah.
opens, that's okay. If not, then I prefer to use shockwave balloon rather than rota, because rota will be small for this artery, because trio, there is no any waste that much. So if we have a big calcium, I rather to use shockwave balloon.
So just to recap, I lost a little bit. So there was the RCA stented, which was the culprit lesion. Patient came with an MI, and now we're working on the non-culprit in the same setting. 2 days later. It's 2 days later. Okay, that's perfect. So okay, and but the LED. So we're working on the proximal LED, and it's a big diagonal coming out as well. So what's the strategy for the bifurcation while you're working on the LED? And since we have IVUS catheter on the table, we might as well use that before we decide on whether to use shockwave or not, or use rota, any plaque modification therapy.
Right. So according to your plan, you will do that bifurcation. You will do double stent technique. Am I right? Because
Yes.
you said that
Yes.
you said that diagonal is really big. It's really big. Yes, it's maybe 3.5, really big one.
But if she's going
Yeah.
for the double stent, the patient has already stent in the ramus. Previously had a stent in the ramus, proximal part.
No. Just.
So is this a 3.0 NC balloon?
3.5.
3.5.
Yes,
So I feel the pre-dilation, the balloon inflation time is too short. So you have limited time to the balloon react to the vessel wall.
You are
So you
right,
need
but
to
it was slide to upper side due to I deflate very quickly. You are right.
Yeah, so if I do this case, I will do the plan modification with the scoring balloon or cutting balloon angioplasty, and especially the distal stented portion still underexpanded. It means that less higher pressure. So the commercially available NC balloon, you can going up to at least 28. And I'm used to inflate up to 30 atmosphere. Nearly up to burst. So nearly we need to going up higher pressure with a little more prolonged inflation to get more adequate space. And if you feel difficult, instead of the complex rotablator, it's better to use the anchor balloon technique or the daughter catheter system to deliver the stent by the. Now you can get more enough space to deliver the stent in this situation.
So I
So
think
if you go to basic step to the
that
more
proximal lesion
adequate
looks
balloon
like
inflation time,
it's
you can get more
expanded,
good pre-dilation effect.
Kadriye. I don't think we need
Too
more.
short pre-dilation
I
time.
think we expanded it. So it looks like from here. What do you think? Is there was any waste on the balloon?
Sorry, I can't hear. Did you ask to me?
Are you happy with the result? There was any waste on the balloon when you do predilatation? It looks okay now. And I
Yes.
didn't see the IVUS. Is IVUS showed classification there? It's circle classification or anything in that part?
Okay.
Proximal LAD?
Okay. I think it looks like a broken.
Pre-dilation looks okay. So I think you can continue.
I'm going to make very quickly IVUS again.
Yes, please, yes. Let's see if everything is okay, right? Because this patient came stent occlusion, so we have to make sure everything is perfect. Pre-dilatation is perfect, post-dilatation should be perfect, so.
Just as a procedural thing, I think for our junior faculty and fellows, once you've stented and you've got a fresh stent mid and distal, at that point, if you're going to go with plaque mortification, you probably don't want to do a rotational atherectomy or CSI at that time because you've got a fresh stent there. And so if you're going there, you know, we do it at times when we have to. But the idea would be to actually have that strategy before you put in a fresh stent, and then you're doing a rotational atherectomy proximal to that and going to the proximal edge of the stent that may still not be completely dilated, which would ablate that stent. So in that case, you would take an NC balloon and, you know, even burst it if you have to, or do an IVL and not use those atherectomy devices, unless you take a CSI and do it reverse coming back. So those, just as a thought process and discussion about atherectomy once you've just put a new stent in.
Stop. Show. Have you seen the IVUS image?
Yes, we have seen it. I think that's okay. The proximal part was a little bit fast, but what I see that it's okay. I didn't see any
much calcium.
Big calcium.
Unbroken calcium.
Yes.
And here is it almost 4 at this level. So it's a big vessel. What I see some stent start at the proximal. It comes from ramus, right?
Yes, it comes from ramus.
Okay.
Okay, give me a second.
So which kind of strategy do you want to do in this bifurcation?
Double kissing cloth.
Okay, very nice. I like that.
I have plenty, yes, because the side branch is as much as larger to LAD, and also degree of the side branch lesser than 70 degree. I prefer the double kissing cloth.
Okay, but in that case, the first stent would be LAD to LAD, right? Because you did already dilatation. I don't know.
Yes, and also I didn't pass easily to LAD. I passed to diagonal very easily, but I can't pass to the LAD very easily. I prefer to stand to first LAD.
Okay.
I think it's very important during procedure.
Okay, which length is it?
This is a 3.5 30 Firehawk stent. Show me some kabul.
Okay, Firehawk stent, macroport.
Yeah. It's from, give me a test. I tried to insert the LAD ostium. Okay, it looks like good.
Yes, the proximally looks okay.
Yeah.
And distally is, there is overlap, right?
I think not.
That Ramus stent was under-deployed also, so I'm afraid if you put a stent in here and then you're going to try to go into Ramus, it might be a little difficult. You may want to have a balloon that Ramus stent before you do that.
There's a very short segment in between the two stents.
For about encore?
Would you not go for overlap stenting? Distal stent and this proximal stent, very short segment. Yeah. Maybe less than 10 millimeter.
But if I forward stent, I have to do overlap the diagonal level. I prefer to implant this stent here, and also I can put another short stent between two stents.
That's
Can
okay.
I explain?
And we have seen some hematoma, you know.
Yes, yeah.
Yeah,
Yes.
because, yeah, distally we have stent, so we have a dissection. So not to inject that much, yeah.
Yes, yes.
Yeah.
I implant stent. Okay. So, just follow. 40? Okay.
So I guess you will do post-dilatation and pot before wiring
Yes.
diagonal, because proximal LED before diagonal.
Firstly, I would like to insert another stent between two stents.
Do you have a gap there?
Yes.
I see.
I have to check.
I think
what
that's
do you
okay.
think?
There is nothing left. No?
Yeah.
Am I wrong?
It looks good. I don't think so. There's a need to put stent
Yes,
even though
yes,
there's a
you're
gap.
right. Yes.
I mean,
For a balloon?
Yeah, maybe there is a gap, but it looks fine.
Yeah, it looks fine. So there's
Yeah.
no need.
There's probably a 3-4 millimeter gap in between the two
So
stents. Is what
I
she's
suggest you to
about
leave it like this. At the end, let's check by IVUS. If there is a dissection, edge dissection, anything, we can put a small stent. But I suggest you finish bifurcation.
Later on, you will get a higher chance of recurrence in over there. So I agree to implant one more short stent in the middle segment.
Is this
I
4 or
agree.
4.5?
I agree.
Otherwise, definitely the statistics is showing the higher chance of recurrence.
Is this 4.0, 4.5?
Yes, 4.0. This is
Right.
a 4.0 balloon. NC balloon, I did at 20 atmosphere. I tried to just to Karina.
So we have to post-dilate distally, right? It looks
Yeah.
a little bit
I
underexpanded.
will do it during the first kissing. Okay. Okay. Now. Yeah, another wire.
According to IVUS, the distal of the LED, the diagonal is like 4.0, but the proximal of the LED looks like 4.5. So I think we had better do post-dilatation by 4.0 of the 3.5 stent, and then later on pot with 4.5 maybe at the very proximal. That's what I would do. But now you will rewire the diagonal, and then do ballooning, and then you will do kissing.
Yes, I will do first kissing.
Right.
So you would be wiring from the distal struts, right?
What about ACT?
Yes, ICT is very important.
So you would be trying to cross it from the distal struts, right?
Yes, I try to pass to distal strut. Else I have planned to double kissing cloth.
So you can go
What
into
wire
the
do you have?
LED and then come back, maybe that.
This
would
is
help.
a workhorse wire.
Okay.
Which is,
I never tried firstly hydrophilic wire.
but workhorse wire, which one is it?
Boston choice wire.
Choice wire, okay.
Yeah, again, for the junior faculty, what I was referring to, if you looked at the IVUS run, as we got across that ramus or high diagonal, you call it, there was an under-deployed stent that was jutting out into the LAD a little bit. So if you put a stent across that, it's just going to be that much harder. They will get it in, but it's just going to be a little bit harder to get in. So in a perfect situation, you would dilate that ostium a little bit more of that, and then go in. Now put the stent across that.
You have seen, I think I have passed to distal strut. I will open first a very small balloon. After that, I will dilate it with NC balloon.
So with the help of anchoring balloon, which you can inflate distal of the diagonal, you can also insert any NC balloon. What do you think? Then you can save a small balloon and then save some time. What do you think?
Yes.
Because you will do kiss
We have
anyway.
a lot of area for anchoring distal part of the LAD.
Yeah.
Yes, dilated.
So would you like to remove?
I never removed.
You have to remove the other wire.
Yeah, the other wire because.
No, not yet.
Okay.
I need a gel wire, I think.
Yeah, the jail wire.
A gel wire, yeah, but I'm afraid a little bit if I crushed it differently in that level. I always, after crossing with balloon, I always remove gel wire.
Exactly.
Yeah.
You always remove during first kissing.
Yes.
Okay.
Before any dilatation of the ostium of the
404
side branch.
LAD, 304 diagonal.
And these days we do DEB a lot. I don't know your practice here in Pakistan, but in Turkey we start to do more DEB than before. And
which one?
For example, for this diagonal, I like to try 275 balloon, for example, if there is no dissection, or trio balloon according to size. If there is no dissection, then I like to do DEB for the side branch. Even it's big, no worries. If there is no dissection, that's fine. And then kiss, yes. Yeah.
But when you go through the stent, doesn't the drug come off the
No.
DEB?
No.
If you dilate with 2.5, then drug should not penetrate. Even 2, done 2,
So I would just give a different example. This is a first cross wire, so you don't have to take the main wire out yet. If they're going to do just the balloon of the side branch first, and then don't have to take the main wire out. You can if you want to, but at this point you don't have to. Once they put the stent on the other side, obviously that would be jail, and you have to pull that out.
Alex.
Yeah, but last touch, still, yeah, I agree with you. Last thing should be DEB with kiss. Kiss with DEB. Is this for all?
Yes,
Very
this
nice.
is for all.
Very nice.
For post dilatation and also encore. It will be.
Your first gel wire is still in place or you remove it? We didn't
Yes,
see.
yes. I will remove it
You
when
will.
I insert the diagonal balloon.
And this NC balloon, is it 2.5? Which one is it?
Which one? Diagonal?
Diagonal one.
Yeah, trio.
Okay, nice.
This is a gel wire. Yeah. I remove the gel wire.
So you remove gel wire very easily. It tells me that proximally.
No, it's not easily. I'm very strong, as
Really?
you know, Ömer
All
abi.
right, okay. There is no deep engagement. That's why I told you. All right. Okay.
Okay. LAD.
So you have a nice GL, means nice opposition at the proximal.
So I heard you were considering double kissing clot here, but since you already have a stent in the branch from before, as Dr. Umar Godkin also suggested, if you have a DEB on the shelf, would you consider after kissing doing a DEB in the side branch? Drug-eluting balloon.
Okay. Yeah. Okay. Give me a test. Yeah. Okay. It's normal. Don't worry.
Yeah, and inflated. Yeah. Exactly.
Dilated to
So
diagonal.
that's a good point. So what Suhail Aziz comment on me, which is very good and very valuable. Normally, you had better do first dilatation at the stent strut, at the carina, because this is trio and C balloon. After deflation, it's sometimes not easy to pull back to carina because of the small size of the strut. So it's better to do first carina inflation to open side branch strut and then go more distal. It's better.
Yeah. Yes.
Yeah. Sometimes I had some difficulties. I think Suhail also had some. That's why he's saying that.
So you are doing sequential first?
Yeah. No, we can destroy that part of the stent when we pull, especially for kissing provision. Okay. That's important.
Dilated. Kissing.
Adria, we are left with only 5 minutes for your transmission.
We have only 5. Okay. Done. We have an image to decide to.
Yeah, I can. It will finish in 5 minutes. Very nice. LED looks very nice, and we implanted big stents. We dilate for all, so the risk of restenosis is very low for the LED. I'm very happy. So let's see. Yeah. I mean, yes. This vessel is big vessel. Yeah. I look for if I could do 3.5 post dilatation at least for diagonal. 3 stents and 3.5 post dilatation would be very nice if we could for the restenosis rate.
About ACT?
Did you give additional heparin and?
Yes, we gave. Okay, ACT is now 333.
So what size of the stent are you taking for the diagonal now?
I have a trio 35 millimeter Firehawk stent.
45.
I didn't remove 30.
So, I know that you did it on purpose. You leave anchoring balloon in place if you need it, right? Very good.
Yes.
Very nice.
Yeah. I leave it there. I will remove when I pass stent to diagonal artery. I am okay.
I think 7 French. Your guiding is 7 French, right?
Sorry, say again, please.
Your guiding is 7 French.
Right, Catherine.
Yes, 7 French.
Yeah.
Yes,
I don't like 6 French.
Using anything other than 7 French.
I have to check the distal part. Here, yeah. Left cranial.
1 millimeter down, maybe. Proximal, we have, I think, good space.
Okay.
Yes, yeah, mini cloth, yeah.
What do you think about overlapping parts? Looks good?
It needs to come back a little.
You know, if you pull back a little more, it will be useful. You may have a difficulty in crossing otherwise.
Yeah.
Okay.
So this is going to be a mini culotte then.
I think it's okay.
That looks much better.
Looks good.
I think it's okay.
That's better. That's better.
This is nice.
Sure,
Yeah.
that's much better.
Okay.
It looks nice. And before the wiring of the LED, we had to make sure we expand the proximal stamp strut, right? So
I will do.
I
will do 4.5 balloon.
Yeah, I know you will do it, but I would like to explain the audience, Kadriye. I know what you do exactly. Don't worry.
You have to know. I have learned a lot of things than you.
Kadriye, there is a role of protection balloon at the level of diagonal and LED or not?
Well, sorry, I can't understand that way.
I see.
4.5 balloon. Could you say again, please?
Is there any role of protection balloon at diagonal LED junction when inflating this?
No.
I suggest 4.5 short balloon for the proximal part if you have Kadriye. This is big LED, yeah.
Already we don't
for
have
example,
4.5 balloon.
If you look IWUS now, we have on the screen, I count 1, 2, 3, 4, 5 millimeter. I don't know where is it, but
more or less 5 millimeter. You are
it's
right.
obviously the big one. Yeah.
I4? What's the length?
Yes, you can. Yeah, you can. And it's so there is a stand anyway to do. You know, most of the time, what we think that if there is a discrepancy between side branch and main branch, cloth is not good. Yes, we think about it. But with mini cloth, it doesn't matter because not here because this is inverted cloth or inverse cloth. But if you put first stand from the LED to diagonal, 1 or 2 millimeter will come to LED, only 1 or 2 millimeter. And then you can expand it as much as you. Even you can break it because you will put another stand and you cover everything.
Kadriye, we are left with only 1 minute. Transmission time is
Exactly,
only 1 minute.
but still here it's not an issue, yes.
Now, give me a new wire, please. I have to check proximal part with stand player. We don't have a lot of time. I will try to rewire LED for last kissing.
And yeah, nice. This is nice coverage of the Karina.
This is a 5 balloon. Hold the wire.
Is this, which balloon is this?
5-0.
Ah, okay. 5-0. 5-0 post dilatation. Pot. Nice.
Pot. Yeah,
So, and then you will rewire it. And for the LED, I think you will have 4-0. For the diagonal, your size would be
3.5.
Okay, very nice. I think this is the maximum we can do, right? Even we do IWUS, what can we do? We cannot do 4-0 for the side branch, yes? Maybe we can go 4-5 at the proximal LED, maybe, according to IWUS. But the side branch, 3.5, I think the maximum.
So I think I'm going to ask Dr. Kadriye, this is Bashir Hanif. I had to take over for a few minutes, and before I close the session, I would like to ask the final comments from the panelists. Quickly, Dr. Ra and Dr. Tariq, and then from the panelists here, and then we are going to close the session for today because we have a meeting coming up. So, Dr. Ra, any final comments?
Actually, she nicely demonstrated a good case for this complex bifurcation case. But in my personal opinion, this is a acute coronary syndrome setting. It's a high chance of slow flow and no reflow even in the 3 days after the index procedure in ACS status, acute thrombotic milieu. So even staged procedure, so in my personal opinion, less complicated procedure and simple procedure will be better in this particular setting. So if I do this case, maybe because I can see the balloon response in the side branch, the diagonal branch was relatively favorable, then I would have done the DCB in the side branch and the left main LED stenting and finish in this particular case. If recur in the diagonal branch, maybe I will do elective 2 stenting strategy in the near future if recurrence. And if I do the primary 2 stenting, if side branch balloon response is not favorable, then maybe I used to do the mini crushing stenting because the primary cular stenting next to recurrence, I have no other stenting strategy. So mini crushing stenting, then maybe we can do next recurrence, can do cular stenting to cover the mini crushing recurrence.
Thank you.
So in stepwise, I'm considering the next recurrence. So that is my personal opinion for this particular case.
Thank you. Thank you very much.
Nice demonstration.
Yeah, if I was doing this case, I didn't really see any significant dissection in the diagonal branch after the balloon. I would have probably just either done a drug-coated balloon or just left it alone. I'm not sure, again, it's my view, but I may not have put a stent in there. We know that putting 2 stents in there is going to be more problem than a single stent, especially when it comes to diagonal and LED. Dr. Tariq Shahab, do you have any comments?
Yes, and
Final.
First of all, I think really a good case from Turkey. I think it was an excellent demonstration of bifurcation stenting. And congratulations to you and your team for showing up, arranging these cases and the conference. It was really very well done. In regards to this case, I agree. This was a good case and they approached it well, but there are different options to let the fellows know and others who are starting. I think in the setting of acute MI, I would have staged it later because this was a complex bifurcating lesion and not do it in the immediate setting unless the patient was unstable. And I agree that instead of the quality technique, I would have done a reverse Y stenting, doing the main LED stent and bringing the diagonal stent up to the carina and then doing a kissing balloon on that. So that would be my approach in this setting. But
Thank you.
It looks like good and the results are good. So either approach was fine, I guess.
Thank you. Dr. Noori, any final thoughts from you?
I think an excellent demonstration of bifurcating diagonal LED lesions. My only slight reservations are that the proximal part of the LED stent is a little underexpanded. This probably should have been 5.
Okay, Dr. Nadeem Malik.
I mean, obviously the concern in this young patient who had a thrombosis in the RCA stent would of course be the double metal layer in the proximal part with the culotte technique. And if you are going to do a culotte, I mean, this is like a mini culotte, but I mean, you still need to get an optimal result in the proximal part where you have got the 2 layers of metal overlapping. Yeah. So this is probably a case for getting as good a result as possible before you end it because of the risk of stent thrombosis.
Okay, Sohail?
A very nice case. Initially, we didn't actually get to see the whole cine, so we didn't realize the bifurcation, and we started commenting on the moderate proximal LED. But with that huge diagonal, this was a very, very nicely done case. And,
thank you. Dr. Umar, the only concern I have is that if the diagonal stent was like, well, I think 2.5 or 2.75, and we know LEDs are like almost maybe 4, And if we don't, I didn't see a port with a bigger balloon before you rewire, you may be going under the diagonal stent strut. So wouldn't you like to do a port with a bigger balloon before you rewire into the LED?
Exactly. This is a very important point. We have to do, after implanting stent for mini clot from side branch, we have to expand the main part of the stent, which is 2-3 millimeter. We have to expand it, according to main size, main artery size. Otherwise, easily we can cross, and anything can cross easily. We can crush. What we'll lose nothing, because in that case, our technique will be crush technique rather than clot. Because at the end we will do kiss. If we kiss at the end, everything will be fine.
Okay.
But if you want to do clot, you have to do pot.
Okay, so I think we have to end the session. Dr. Kadriye, thank you so much. Great case and excellent results. So we'll leave you for the final results over there.
Yeah, thank you, Kadriye.
Thank you.
Great case, and you see that the ostium of the
few times, I would like to show you last corner angiogram. I'm doing a last kissing.
Okay, we will.
Okay.
But look.
Okay,
look
we'll give you another
stent.
minute.
You need the proper pot, because the ostium of the stent looks a little bit.
This is I have to. Sorry, this is the jail wire.
In the stent clear.
Hold it. Okay. Inflate. Diagonal. Yeah.
What is the side branch?
Inflate. Yeah. 3.5 balloon.
Nice. I like this.
Okay. Kissing. Come here. 3 balloon is to LED. Sorry, 4 balloon to LED and 3.5 balloon diagonal down.
Did you post dilate the side branch all the way?
Yes.
Okay. Nice.
I post dilate with 3.5 balloon.
Yeah, but according to stent boots, you need to do another pot at the exactly ostium of this stent. Oh no! Don't deep injection.
So if you can just take a final picture and show us, then.
Yes. This is the final picture.
Okay, good.
But you will do pot, right? Very nice.
Very nice. Looks great case. Thank you so much.
Perfect results.
Good results. Thank you. And I would like to thank all the panelists. I'll quickly show the last final result of from PIC, that right coronary case Dr. Salman shared on WhatsApp, and I thought I'll just show the final pictures. Can we just put that on? So that right coronary artery.
I am sure that you will see the distal vessels if you have any perforation. I don't think so, but we should do all the time, right? Yeah, let's. Of course, you will check it.
Okay, so this is the right coronary. Dr. Salman did it, and if you look on the right side, he put a stent in the proximal part, and distally he did a drug-coated balloon. So although the distal vessel distribution is not that great, but overall looks excellent. So he wanted me to show over here, so I thought we'll do that. So I think we are going to end from today here. Thank you very much, everyone, all the panelists, online, physically who are here, and all of you staying so late. So be here tomorrow morning at 8 o'clock. We have a nice structural session with a live TAVI case that will be transmitted from Barry Hospital. So see you tomorrow morning. Thank you very much. Have a nice day.
Yes, very good.
And we have a general body meeting in this hall at 6:30.
The vessel is non-CTO. I cross with let's say, a guy.